want to start over there in the center.
Good.
2, 3.
Well, hello, everybody. I notice most of the people here are my patients, so you're going to hear a lot of redundancy today. I probably already told you about what I'm going to say. It's a few new things, but today we're going to start talking about spinal cord stimulators and peripheral nerve stimulators. And it's been around for a long time, but the technology today is very advanced. Some people who have already had them put in years ago, they work a lot better today. And the spinal cord stimulator is something that we almost use that as a last resort, especially with people who have surgery. And usually we have surgery, you're left, the majority of the people are left, I'm talking open spine surgery, the majority of people are left with chronic low back pain because of the fact that they make large incisions. Some of them are small incisions, but that's not the surgery I'm talking about. I'm talking about major fusion, big incisions, multiple levels, and then after they fuse one level, you got to fuse another level, then it's more surgery, and they're basically peeling the muscles away from the spine. And when they peel the muscles away from the spine, the muscles never really come back. They become atrophied and weak, and you get chronic pain. But and a lot of these patients, the only way to get rid of their pain is either spinal cord stimulator or peripheral nerve stimulator.
Say that again.
A peripheral nerve stimulator or spinal cord stimulator. And what I'll tell you about that is, basically what we have is an electrode like this. You see the end of it? You can barely see it, but they have electrodes on the end here, and you usually can get one or you can get two. But these go into the spine in the epidural space. Here's a picture of one here. You see it goes into the spine. I place these in the spine, and they go to a certain area which we call the sweet spot. Once you get the right area, you turn it on, and the patient's awake. It's a simple procedure. You really don't need any sedation. You're better off without sedation so you can communicate. Because once we get it to the right spot, then the technician, who are here now, who know how to control the computer, and they turn it on, and they ask you if the pain is in the same area, or the sensation is in the same area as your pain. Now this is almost, we can almost talk about that's the old way. Today, well, the old way, it turns your pain into a warm tingling sensation. If somebody has severe pain, and you get a warm tingling sensation instead of a severe pain, especially down your legs, it's something that is very acceptable. It tricks the body. It goes into the spine, near the spinal cord, and it just tricks the brain, and the pain goes away. Now St. Jude, they're the people here today that I use their spinal cord stimulator at this point. It's a very good system, and they came out, and I think you guys are the only company that has it where you don't even have a warm tingling sensation. I can't personally tell you if that's what it does, but they just told me about it this week, where you don't even have the warm tingling sensation. It just makes the pain disappear because of the fact that by tricking, it's correlated with the frontal lobe of the brain and different areas of the central nervous system where you don't feel the tingling sensation. It just stops the pain sensation, which is fantastic for a lot of people. However, we try to get rid of the pain. That's my goal, is to get rid of the pain. And I'm pretty good at it. I'm doing it for probably 25 years. There is a new system that they have, what they call is a peripheral nerve stimulator. That we found out that with the spinal cord stimulator that goes into the spine, it doesn't really work too good with low back pain. It works great with peripheral pain, the neck, down the arm, and the legs and the feet. It works great for that, but that low back pain that some people, no matter what you do, and I have to say sometimes it's hard for me to get rid of it. And then when they came out with this not too long ago, it really works fantastically. What we do is with that, if you have a section of your back, and let's say it's this much pain, or even this much pain, or some people the other day I did a patient, it was only this much pain, severe pain, no matter what I did, I couldn't get rid of it. I already went to 10 different doctors, just couldn't get rid of the pain. And just chronic pain, most likely from low back pain from post-surgery. And now what this does is you can put in, I don't have two of these, I should have two of these. Here it is. You put in two of these, let's say the pain is right here, you put two of these on either side of it, and they communicate between each other. And when they communicate between each other, they give that sensation of warm tingling sensation. And they've made me aware that even the new system will just get rid of the pain. I haven't seen it yet, but we'll try. We'll see. I haven't done any patients yet with the new system, but you can program it to go either way. And that's the spinal cord stimulator. It's a great way to go. Like I said, I try to get rid of the pain. And the way I get rid of the pain, you take the typical patient that comes to my office who has low back pain, sciatica type pain, they have neck pain, and they have pain running down their arms. That's a form of sciatica pain in the upper neck, coming from the neck to the spine. My forte is any pain derived from the spine. However, I also do now, I've been doing it for years, I do pain from the joints, general arthritis of the spine. We came out with new stuff now. I constantly evolve here with the Jasper Spine Institute. The latest crave now is even the patients are asking for it, and that's the stem cells and PRP, which is platelet-rich plasma. And the difference between that and an intra-articular steroid injection, it's a couple of major differences. Steroids are great. If you have pain, inflammation, you give an injection with steroids, which is an anti-inflammatory, you've all heard this from me already. It decreases the inflammation, therefore decreasing the pain. But at the same time, steroids are not real good for you, especially if you use it too much. What it does is a steroid breaks down tissue, breaks down protein. If you have an inflammation, you get rid of it and it doesn't come back anymore, steroid's the best thing. But if you have a continuous arthritic joint, let's say a knee joint, especially knee joints, there's a lot of studies in stem cells, PRP. Knee joints, if you have pain from arthritis, especially sometimes it's advanced, you give the injections, it might work for a month, 2 weeks, 2 months. But when you have a little bit of cartilage left and you give them stem cells or PRP, what it does, instead of breaking down the tissue and decrease the inflammation, it will decrease the inflammation of the joint, of the arthritis. And at the same time, it calls upon stem cells, growth factors, and it causes this little inflammatory process that calls upon all these cells. And when it calls upon these cells actually regenerate cartilage, they regenerate tendons. So it's good to use this for a tendinitis. It's good to use it for if somebody has a torn rotator cuff. Now I'm not talking about a complete tear. I'm talking about partial tears. And they've proven by doing this with studies that it regenerates even the tendons and the ligaments. As I said, my typical patient is a patient who has sciatica type pain caused by spinal stenosis, herniated discs. So the first thing we do is, we have a crew in my office that you all know. The nurses see it initially, and they do a complete history of physical examination. I come in later on, I do a history of physical examination after the nurses see me. And I come to a conclusion, most people need an MRI, especially if it's derived from the spine. And one of the differences that I've seen myself, especially because I teach a lot of doctors how to do the stuff that I do, a lot of them don't know how to read MRIs. They rely on the MRI reports. And you can't just rely on an MRI report because the radiologists, no matter how good they are, they do not know the patient. We know the patient, I know the patient, I know where the pain is. And by knowing the dermatome distribution of the pain, which is this here, this is just common knowledge in my field. If you have pain in a certain area down the leg, let's say you have pain into the groin, that's usually 2-3, L2-3. You have pain on the anterior thigh to the knee, that's 3-4. Down the calf is 4-5. The ankle foot area, that's a 5S1. So first thing I do is, if you got pain in your foot, I look at 5S1. In the calf, I look at 4-5. I specifically look at the MRI for these problems. Whereas a radiologist doesn't know where your pain is. They just describe everything. and there might be little significant things there that they see. Sometimes I see some really bad MRIs. I see a little spur coming out of a bone that's rubbing up against a nerve. They might not notice it, or they might not think it's significant. I do think it's significant because I know what your pain is. And that's one of the reasons why I have pretty good success. And also, the reason why I have good success is because when I place needles, I place them very precisely. I was born with the talent of placing a needle. And it all has to do with my artistic abilities. I've drawn these here to show my patients how my procedures are done. This is the endoscopic discectomy, which I'll talk about. And another reason why they work, and you've heard this before, some of your patients, that I use expensive steroids, where there are steroids that are cheaper that really don't work that well. But that's another story. Now, what happens is if a patient comes and has a herniated disc, and by the way, everybody should know that somebody has sciatica pain, overall, 80% of them will probably get better on their own. That's a known statistic. However, if it gets to the point where it just decreases the quality of your life, you can't do anything, you're sitting around, just by sitting around will increase the chances of you having a blood clot, get out of shape, your muscles start to atrophy, you can't move around, not breathing right. You need to take care of it sometimes if the pain is severe. Some doctors give you pain medication. I do not give pain medication. I might give pain medication after a procedure that might have caused a little bit of pain with a little incision. I might do that, but I don't believe in treating patients with pain medication. I believe in going to the cause, finding it, looking at the MRI, and taking out the pain generator. That's what I do. But anyway, back to what you have to do is you have to find where the pain generator is and take it out. So if you got a herniated disc, I give the injection. The reason why I give the injection because the nerve sometimes is swollen. A lot of you have heard this before. When you have a swollen nerve that's getting pinched by the herniation or maybe some bone spurs, you give the injection, it decreases the inflammation, decreases the size, and shrinks the nerve down. And hopefully when the nerve now is a normal size, you'll be able to live there without chafing, and you can go a pretty long time without having pain. Sometimes forever, unless you re-injure yourself. But if you get to the point where you can't, you get to the point where it just keeps coming back, the epidurals don't work, still got pain down the leg, and then I do what they call as a spine nerve decompression. It used to be called endoscopic discectomy with foraminotomy, but we have tubular decompression now. There's all different names. And basically what it is a nerve that has structures that are actually crushing the nerve, and you give the injection, decreases the inflammation, it doesn't go away. You have to remove these structures because it's not, as I say, hocus pocus. I mean, and it's not rocket science on how to get rid of this pain. You're not going to go to a surgeon and say, I'm going to get this fixed, I want it fixed once and for all. And then they do big surgery, because big surgeries are sometimes come with major consequences. They actually have a code for billing, which is called failed back surgery. And there's a lot of codes like that going out there. My goal is not to send anybody for major surgery. I send out maybe one patient a year, or one every 2 years for fusion. When the spine is unstable and it just moves around, and every time you move, you got to stabilize it. That's fusion. That's what fusion was designed for. Fusion isn't designed just for low back pain. It's not designed to get rid of sciatica pain. What's designed to get rid of sciatica pain is get the structures off of the nerves, and the pain goes away. Like I said, it's not rocket science. It's anatomy, it's physics. So crushing a nerve, you get it off, pain goes away. And that's what I do here. I make a little teeny incision, maybe 4 millimeters, 1/3 of an inch, and I go in there with an endoscope, and here's the endoscope. It's a lot smaller than this, but also your spine's a lot smaller than this too. And through here, somebody put this out of order. First thing I do is I take the herniation out. Once I take the herniation out, this scope, I could come in here with instruments. Now this is on a big monitor, big high definition TV screen. I can see it. You can Google this. You can actually see the whole procedure if you Google me and this procedure, an endoscopic discectomy or a tubular decompression. And I see that herniation. I put graspers in there and pull it out. Once I pull it out, the herniation is gone. And the nerve does not have any pressure on it up against the bone. However, sometimes there's just such little room in there because of degenerative disc disease and arthritis. You get some bone spurs that are rubbing against the nerve, and I can trim those down with, if I choose to use laser, I can use reamers, I can use drills, I can use files, chisels. Any way I can come in there with fine instruments to smooth it out. And once I smooth it out, this nerve, under direct visualization, I can see that the nerve is now decompressed and the pain is gone. Sometimes with the older population, they have so much pathology in there that if a person, let's start with a young person who all they have is a herniated disc, right? And somebody who's 25 years old, 22 years old, 32 years old. I had a patient probably about 6 months ago. He was laying down on the floor in my waiting area, couldn't even move. He had a big herniation. It took me 15 minutes to get it out. I went in, took it out, got off the table, pain-free. And he's been pain-free ever since. Might have been more than 6 months ago. Those are a home run. Young person, no stenosis, they have no arthritis, no degenerative disc disease. They just have a big herniation, put pressure. The pain generators, pressure with the hernia, take it off, it goes away. Now you have an older population that probably too old to get major spine surgery. If you go to a spine surgeon, most of them, if they're good and honest, and you got multiple levels, it's hard for them to figure out what levels to fix, and they don't want to deal with it because chances are the success rate is going to be very low, and they don't do it. And then they come to me, and I do this minimally invasive spine surgery. And by the way, Medicare patients, as some people in this room know, that Medicare doesn't pay for most of the procedure. So that's another downside. But if they did pay for the procedure, I would be able to pick off one level at a time until we get all the levels. Even in the older population, it's hard to do a lot of spine surgery because each level has so much arthritis and so much debris in there, because when you have chronic inflammation over years, it's not just a herniation, just some bone spurs. This roof, the roof and the floor, because the disc is gone, is a lot smaller. So you got to trim some bone down up here. Anytime you're pushing a nerve to the side, you're moving around, you're manipulating a nerve that's already inflamed, a lot of times the pain does not go away immediately. It can take a week, 2 weeks, months, a couple months for it to go away. Sometimes I have to do another injection to continue the healing process of the pain of the nerve. And sometimes there's scar tissue in there. And you don't need to even have scar tissue, the older population, from surgery. Usually scar tissue means surgery. But I've seen it in a person that had basically a virgin back with no surgery, with a lot of scar tissue, and that's caused by chronic inflammation. Inflammation causes scar tissue. It becomes very difficult. And that's one thing that I do, which is, this is a wonderful procedure. I wish one day the insurance companies would pay for it. But that being said, another procedure is that I do gets rid of a lot of pain. One of the most severe pains that I've experienced, and also my nurses and staff, is somebody with a broken back. Broken back, compression fracture. Has anybody ever had a compression fracture here? Thank God. Compression fracture is a fracture of the vertebral body. Here's the spine. You have the vertebral body, and you have the disc in the middle, and then another vertebral body. And in the older population, and also younger women that are postmenopausal, the bones start to get weak. They start to get osteoporosis, osteopenia, and the bones get weak. And if you fall, especially fall on your buttocks, you get a lot of pressure on the spine, you can crack this. And when you crack it, it's very painful. We can tell when a person has a fractured back when they come in. They can't sit down, they can't stand up. They got a face, they have an expression on their face with severe pain, and they can't move. It's hard for them to breathe. I send them for an MRI with a special technique, which is called the stir technique. You can see it light up. Once you see it light up, you get rid of the pain. And the way you get rid of the pain is you have the front part of the spine and you have the back part of the spine. And then connecting it is what they call pedicles, which is a bridge from the vertebral body and the posterior part of the spine, the back part. So that's a bridge. I could stick a very thin metal straw instrument as a point, and I tap it very gently into the center of the vertebral body, which would be inside here, right to the center. And what I do is, it's called a kyphoplasty. I put an epoxy, they call it cement, but it's an epoxy. You mix it, it heats up, causes a chemical reaction, comes out like putty. It's an epoxy, and it fills all the cracks. Because the pain is caused by a broken bone. If anybody ever had a broken bone, when it's broken, it's moving, it's severe pain. As soon as they set it, pain goes away. So what that epoxy does, the cement, it fills all the cracks. Because of the chemical reaction, the temperature of the body, within minutes, it hardens and the pain goes away. Probably 95% of the patients that have that severe pain, when they get off the table, are pain-free. Now, the compression fractures will heal up on their own. It could take 3 months, it could take a year. I've had patients that have severe pain after a year and they still have it. It depends on how much your bone will heal up, how much calcium deposits. First of all, it's fractured because you have poor calcium, so for it to heal up on its own, it's hard for it to heal up. Meantime, you're in severe pain. And the insurance companies do pay for that, thank God. And the reason why, I think, is because if a person can't breathe and they can't move, you have, as I spoke about before, you can have all the consequences of not breathing, not moving. You can get, lungs can collapse, you can get deep vein thrombosis, pulmonary embolism, you get a lot of bad things. So that's why they pay for it. They don't want to pay for the other stuff. All right, so that's basically it. There's a lot of other things that I do, but what I'd still like to mention again, if all of this does not work, we still have the spinal cord stimulator to fall back on. But lately, what I've been doing is the fact that the patient it's an alternative. When I do this minimally invasive spine surgery, you have to give the person their alternatives. What else? What are their options? Their options are do nothing, take pain medication, go for a second opinion, do an open spine surgery, right? Or do the procedure that I recommend, which is this procedure here, the endoscopic discectomy, or the tubular retractor decompression. And I do give them the option of a spinal cord stimulator, and that is an option. Because some people just don't want surgery, and I don't blame them. It's your choice. You make the choice. The doctor, the nurse, or whoever else it is that makes recommendations will make a recommendation, and they have to give you options, and it's your choice. They can give you what their best option might be, but still it's your choice. And I've had patients that said, you know what, number one, I don't have the money for the surgery. Number two, I don't want any major spine surgery. I have too many friends of mine that had bad consequences of major spine surgery. And let's do a trial. The beautiful thing about this procedure is you can do a trial. It's a very simple procedure. You come in, you don't even need sedation. You put the electrodes, like I said, you put the electrodes at the sweet spot. The patient comes to the recovery room, and the technicians, these lovely ladies standing over here, they will program it with the computer, and you get also the little remote control. You take it home for 3 to 4 days. They teach you how to use it. If there's a problem, if you get home and you forget, you call them up directly, they'll talk to you over the phone. If you don't understand it, they'll come right to your house and help you with it. They're very accommodating. Nobody's ever failed because they weren't there for you. And after 3 or 4 days, you pretty much know how it's going to be. And the majority of people come back and say, yes, I want to put it in. But if you don't like it, you don't want it, we pull the wires out, it takes 2 seconds, and we're done. So I would never deny anybody the possibility or the option to do that. The trial's always, that's why the trial's here to try. And the same thing for the peripheral nerve stimulator in the back. The neck, sometimes you have severe neck pain, we put them in there too. Does anybody have any questions about anything I've said so far?
What's the success rate of that as opposed to your other procedure that you recommend?
What, the spinal cord stimulator?
Yeah.
This thing here?
Yeah.
Well, we have statistics. What's the success rate of,
So theoretically speaking, I'd say if 10 patients decide to go for a trial, my guess is about 8 patients will decide, you know what, this trial is for me, it works. What we consider to be a success is, obviously, can you walk longer? Can you sit longer? Can you stand longer? Can you just do things better? But the truth of the matter is, it's in your hands. Literally, this is the remote that you go home with. I'll just hold it up. Literally, it's an iPhone. And there's
you might scare them with iPhone.
But the good news is, it's only one button that you hit. And you turn it on and you turn it off. So whenever you have pain, you turn it on. Whenever you want to turn it off, you turn it off. So there's not many types of procedures where you kind of can just test it out first. It's like a test drive. And then you make the decision after and you say, you know what, Dr. Jasper, I loved it. Let's talk about the real one. And the real one is a very similar procedure to that of the trial. It just takes a little bit longer to put it in. But like Dr. Jasper said, it's in your hands completely. So it's totally your decision, but not many times that you can try it, kind of try it before you buy it.
But if you had 10 patients,
About 8
how
of
many
them.
of the 10?
8. I'd
8
say
of
about
10?
8 of them will say, you know what, this is for me.
Well, the reason why it's a high success rate is because we don't offer it on patients that we think might not work.
Right.
And a lot of it has to do with the patient's affect, their mental status, and whether they have a good positive outlook on things. You know, if somebody's a pessimist, says, you know, nothing's going to work, I don't care, even if you put that in, it's not going to work, we're not going to put it in.
Right.
Because, number one, it's very expensive for the insurance companies, which, by the way, the insurance companies pay for this.
They do?
Yeah.
They pay for this, but they don't pay for your procedure?
They don't pay for my procedure, which can get rid of the pain that you would need to get rid of with the spinal cord stimulator.
Dr. Jasper, you know my situation, my lower back. Am I a candidate for that or no? If that's,
No, you're not a kid.
I'm not a candidate for that, okay.
No, because you recently just started coming to me,
Yes,
and you have a few pain generators, not many.
right,
You're relatively young,
yes.
so you have a lot of potential. I mean, you might be in the future, just like anybody could possibly be a candidate for spine surgery. You might be a candidate for this. And you know, as you get older, or you get to the point where there's you just can't get rid of the pain, then you'd be a candidate for the other thing. But right now, your back is not that bad. You know, you're pretty simple.
Doc, did you ever do it on somebody who had bilateral knee replacements?
I've done it on patients that had bilateral knee replacements, severe knee pain, and it works pretty good. And in fact, I've already spoke to you about that. I mean, it depends on the quality of your life. If it really decreases the quality of your life, that can make you a candidate for it. And as I told you, as my patient, I told you that there's no big deal as far as you do the trial and you see how it works. She can program it to just take care of where the knees are. And now with somebody like you, it might not turn it into a warm tingling sensation. It might just boom, pain is gone.
So
And I hate to say magic, but they make it sound like it's magic to me.
it's crazy. We just came out with a new type of stimulation a few weeks ago, and it's the same exact type of procedure, but it's just a different way that we program it now. So instead of feeling a tingling feeling, you don't even get a feeling at all. You just get relief.
Have you seen a patient do that yet?
Yes, and it's a complete significant.
That's how new it is for me. I think I put one in when? Monday, or when did I do it? Recently.
Monday.
Monday, I did one Monday, and that was the first time I think we put one in like that.
Yeah, so it's the same type of procedure for Dr. Jasper, it's just a different programming for me. And from what I'm hearing and what I'm seeing, the responses for patients and how I program the stimulator, patients do really well because this new type of stimulation affects how you perceive pain. So it's not just about the tingling sensation, this is gonna help your mood. it affects a pathway to your brain that controls your mood. So you're going to notice, you know, hopefully, a mood change if you're happier.
So
if
you have a
can
button
do
that presses euphoria?
I wish.
Yeah, I wish.
But I mean, long term, listen, we want you guys to feel better. With pain
I have a
comes-
good story, but I'll tell you this. Right now, I think they're recording this, and I'm not going to tell you a story now, but I'll tell you later.
Miss, are you a surgeon?
No.
Are you a doctor?
No.
Then how do you get into this field?
Just
What do you do?
training, extensive training for, I work for a company, Spinal.
What is your title?
So my title is any type of clinical technician. So I train technically to program the stimulator. I don't do anything,
I put it in.
right.
I have no idea how to program. That's what she did.
So I don't do anything
How much
surgical.
training have you had for that?
I've been doing this for 8 years now.
And don't give her a hard time because she just
Yeah.
had a baby a couple days ago.
Today's my first day back, so hello. Thanks.
Boy or
But
girl?
it was a girl. Thank you for asking. But I had to be here for Dr. Jasper just because I know he's done a whole bunch of these, and you know, even from the technical perspective, he is flawless. So you'll definitely get good results long
And
term.
Medicare covers it all?
It does.
Yeah.
It does.
Well, Medicare only covers 80%.
Well.
Your secondary covers
secondary,
20%.
right.
That's the only thing I know about insurance companies.
Good answer. Good answer.
Possibility of, what's the duration of the leads and what's the possibility of rejection?
Well, the durations of the leads last forever. However, they have two different types of generators. They have a generator that's rechargeable, and they have a generator that is not rechargeable. It's a battery. Generator works on a battery that has a life expectancy. Now, what's the latest life expectancy? Depending on how much you use it. Like she said, if you have no pain sitting down, you turn it off.
Yeah.
If you have pain standing up and walking somewhere, you turn it on. When you get there, you sit down and you turn it off.
So basically,
always
the
have-
pain is there, you
always
just
have to have
described it.
You're tricking the central nervous system to not feel it.
So the good news about this new type of stimulation that we have, you don't feel it at all. So you really don't even need to turn it on or turn it off anymore because you don't feel it. You're just getting pain relief. So the idea of now long-term turning it on and off, you don't really even have to worry about that. And the settings are so low now that the battery lasts even longer. So our recommendation is now the non-rechargeable battery. So you never even have to worry about charging the battery. The battery lasts, you know, usually around 5 years or so. And then you just get a
Hope we
battery
do.
change. What's that?
I hope we do.
Oh, don't say that.
Well, you know, the way I look at it, and this is preference, who wants to charge it? I guess if you get somebody 25 years old and you put it in, probably better off having a rechargeable one. But then I look at it differently, which they might not look at it, somebody else might look at it. If I had to get it, it takes me, on a good day, depending on the person's spine, it could take me 5 minutes to put it in. And then maybe if I actually put it under the skin, at the most maybe 20 minutes, a half hour. At the longest, 45 minutes to put it in. And the patients are under sedation, and they're not under general anesthesia. So what would you rather do? Would you rather, after 5 years, go to the surgery center and have one put in and be home out of the surgery center in an hour? Or would you rather constantly recharge it? How often you gotta recharge it?
So you recharge depending on, you know, depending on how you use it. You know, you recharge maybe twice a month, so every other week, but you're doing it for a duration of time. But that battery lasts at least 10 years. So there is a difference. And like I said, it's all depending on settings, and we kind of curtail it to each patient just to make sure that you're getting as much life out of it as possible.
Where do you put that device?
Right in the buttock area.
What about taking
And
showers?
what holds it there?
That's fine.
Is it waterproof?
It's inside. So you wouldn't even know anything's in you. It's like a pacemaker.
in
It's
the back?
like a pacemaker. It is essentially, right.
You have a trial, which basically stays on the outside for 3 or 4 days. Take spun baths. We don't recommend taking a shower. And then once you like it, then you come in, and I create a pocket for that. And I put it in there, run the wires underneath the skin to where it goes, and we close everything up, and it's as if you don't even have it. And I put it in an area, especially somebody has some fat pads, in other words, an area where there's a little bit of fat tissue. I put it in that area, usually above or below the belt line. If somebody wears a belt, nobody wears a belt, doesn't matter. but you put it where you keep, when you sit down, you don't feel it. You lean up against something, you don't feel it. So we put it in a comfortable spot, and you just forget about it. Now this, when we say permanent, nothing's permanent. It can come out. You know, if magically we figure out how to get rid of your pain, then we might be able to take it out in the future. For example, if the insurance companies start paying for the procedure that can get rid of your pain.
Is that a surgical procedure that you have to do?
Well, it's not really surgical, but just for the pocket, it becomes a surgical procedure.
And
Because I
you're
have to make a decision about this big,
David.
and it goes underneath, I tunnel a little bit, goes underneath, and I make a pocket so this can fit in it. And then in the incision, it's usually about this big, and then I close it up, and that's it.
size of it?
This is it.
That's it.
Now what about this one, the small one here?
Here. This is the rechargeable one.
Yeah, the rechargeable one is a little smaller.
And that has to be recharged how often?
Probably about, I'd usually say twice a month, every other week. The more you charge it, the less, the less long it takes.
Yeah, if it's underneath the skin.
Yeah, so
How do you
there's a
charge
little,
it?
good question, there's
In
a
your
little,
butt?
like a wand that we have, that we give you. You just put it right over your buttock area, and when it's connected to a little remote, and when it's done, it goes beep, 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 and it's done charging.
How does it go?
Beep, beep, beep.
We all run it.
What's the chance of infection on that?
So
If you have a parrot, the parrot will start making that noise.
Excuse me?
If you have a parrot, your parrot will start making that noise.
he had a question about infection.
No, I said infection,
Well, infection's very low,
very low.
especially if you do it in a surgery center at a
As
hospital. They
opposed to
keep
your
pretty-
other procedure,
Say again?
as opposed to your procedure, that's.
No, the infections, the infection, I don't know, what is the incidence of infection? It's like any other procedure. I think the incidence is probably less than 1% having any kind of infection. Way lower than 1%. Because it's, we do it all under sterile technique. We do it in an operating room that is sterile. For example, my place here is AAHC certified and Medicare approved, which means that they come in and they look at everything. We've just recently passed credentialing. They came in and checked everything out, and also sterility and infection control. You go to a place like that, the infection is virtually zero, but there is always an incident. A lot of times it depends on how you treat it when you go home. You have to be careful. You get post-operative instructions. If they say don't take a shower, you don't take a shower. If it's bleeding a little bit, get soaked. You clean it with certain type of peroxide, or you come into the office and we take care of it. So a lot of the infections are due to how the patient takes care of it at home. I had a patient that got an infection one time. He not doing this, but it was another procedure, and he came back post-operative 1 week. It was perfect. The next week he came back with an infection. He came in with an old dirty towel on the wound. I mean, so a lot of times it depends on what you do at home. I said, how long have you been using this? He says, a week.
My Lord.
So I mean, everybody's got to be careful.
Do you have to be careful going through screening at the airport or anything like that with that implanted?
No, they give you a card, right?
Yeah, you'll have it, just like with the pacemaker, you'll have an
When
identification.
I have the pacemaker, she has to be patted down, so it'll be the same thing with this?
Yep, same thing. You just have a card, and that's just because, nothing will happen other than, this sound
And
of.
do you have to be careful, like with the pacemaker, do you have to be careful where there's microwaves in use and stuff like that?
I often hear, you hear stories about patients, the microwave turns on. In my experience, I've never seen anything like that.
Any questions about any other procedures?
How long does it take when you're in the operating room to put that
To put it in?
device in?
It might take for me to put the wires in maybe 5 minutes, and depending on where I'm putting the pocket to put it in, the whole procedure is 30 minutes, 45 minutes.
And you're going out the same day?
Yeah, you go home the same day, absolutely. Nobody will pay for you to stay there another day for this.
Now, the stem cell procedure, that's not covered?
No, wait, do you have a question on this or the stem cell?
Yeah, Do you do that under general anesthesia?
No, it's under sedation, under MAC they call it, with local with sedation. But most of the time you don't remember anything. The stem cells, that's a good question because nobody pays for stem cells except the patient. Well, it depends on where you are. You know, if you're in Hollywood, it'll cost you $5,000
Oh, here,
for PRP.
here.
But stem cells, usually I do PRP because stem cells are very expensive. PRP for, let's say, one injection in one joint would be $750. Where stem cells would be more like $3,000 to $4,000, depending on where you're putting it. Because the difference is, I'd have to retrieve the stem cells in the iliac crest. We'd have to bring it to the operating room. We have special instruments. You see this thick part of the this is called iliac crest, part of the pelvis. I got to go right in here under X-ray, and I got similar to that needle, that little thin straw with a pointed tip that I was telling about, the kyphoplasty. We go in here, and I go into about this level, and inside here is bone marrow, and the stem cells are retrieved from bone marrow. You know, if somebody's got lymphoma, leukemia, they will retrieve the stem cells because when they do give chemotherapy, radiation therapy, they will kill your natural stem cells. And they freeze the stem cells and they retrieve it the same way, or through the sternum, and they freeze them. And then they replace them with stem cells. So it's the same procedure. It is an extra procedure. We got to take the stem cells out of here, and then we have to spin them down with a special centrifuge, which has a certain amount of RPMs. The inclination's a certain way, and where you get almost pure stem cells and some growth factors. And then once we do that, then we take that and we place it into wherever we're
So you
going to
take
treat.
out the stem cells, and then you put them back in?
Then I take, let's say you need stem cells, somebody has a bad knee joint, and you want the knee to regenerate.
Well, I have fake knees, so.
No, I'm just saying, somebody has bad knee joints because they have arthritis, maybe not severe arthritis, but by the way, you do get better even if you have severe arthritis because it regenerates whatever's there, and it's, you know, what's the alternative? New knee, new hip? Some people don't want that. So they're going more for the stem cells. And the stem cells, like the PRP, platelet-rich plasma, it will regenerate, it'll decrease the inflammation. It'll do a lot what the steroids do, except it's not breaking down tissue. So theoretically, it would last longer. Whereas compared to the stem cells and the platelet-rich plasma, the platelet-rich plasma you take out of a vein, you spin that down, and you inject that, which there's pretty good success rate with that.
Doctor, am I a candidate for one of those two? The stem cell and the PRP?
Well, it depends on where your pain is. Now,
Well, you know, the lower back.
Well, we are putting stem cells and PRP in the back. There are some studies on it. There's not a lot of studies. Right now, the majority of the studies are on intradiscal injections. In other words, if somebody has degenerative disc disease, not severe, but the beginning of degenerative disc disease, that can give you what they call discogenic pain. For example, somebody has low back pain because the annulus, here's the disc, and on the outside of the disc they have a strong fibrous tissue, which come in layers. You can barely see them. In the center is the nucleus, which is softer, and that's usually what ruptures. What ruptures is, as you get older, you get degenerative disc disease. And by the way, some people are genetically have more advanced. Even at 30 years old, I've seen it in someone 30 years old worse than somebody at 80 years old, because genetically they break down. So that would be a perfect candidate. Somebody that has advanced young degenerative disc disease, you inject it in here, and the stem cells, technically, not even theoretically, will rebuild the tissue, which is connective tissue. Because what happens is, the theory behind it, a stem cell is a virgin cell. It's a cell that could potentially become any cell in your body. So if you put it in the environment of a disc, it should regenerate to that material. If you put it in the body of, let's say you put it in your joint cartilage, it starts to regenerate cartilage. You know, any stem cell will do that. There are studies now, and they're doing this for advanced lung disease, lupus. They're doing it for Parkinson's disease, diabetes. It goes on and on and on.
Really?
Now, what they do with that, they take your own stem cells and they give it to you intravenously. And they've shown that people with pulmonary disease, like COPD, that they're improving on their respiratory tests, you know, the lung capacity tests. They're improving. Now, there's no long-term studies on this yet, but if somebody wants it done, they can have it done. I haven't started doing that yet because I'm a very skeptical kind of guy. You know, you have to prove to me it's going to work before I do it on my patients. But you can easily call up down in Florida, and they're doing it for $10,000. You take your stem cells out, they give it to you intravenously. If it works, it works. If it doesn't work, you just spend $10,000.
But the PRP you do.
Yeah, I do the PRP and I do stem cells. I do stem cells in joints and also in ligaments and tendons. But I don't do it intravenously with that until I see some substantial studies.
But in my particular case, I mean, we can't speak about it here. We have
Well,
to
no,
keep the word straight.
I have to review your MRI and
Okay.
give you a definite answer on that.
Okay.
Since I've seen your MRI, I've probably seen about 1,000.
I understand, sure. I understand.
You mentioned earlier about a third of an inch incision.
Yeah.
I don't know what you call that, but is that what you meant as part of surgery, or was that what you meant with surgery, or did you mean something that an orthopedist might do?
No, when I say 1/3 or 4 millimeters, or close to it, that's this procedure here.
All right,
That's my minimally invasive spine surgery.
all right. Now, what is the history of that? Is it success rate and success be?
Well, I've done. If you read my studies, and I can give you my studies before you leave. But I've done studies, retrospective studies, and had them published in peer-reviewed journals. I probably had a good 6 or 7, maybe 8 studies done on peer-reviewed journals, and my success rate was 94%, which is a pretty high success rate, and that's going across the board, where that's maybe 400, 350, 400 people from all ages, anywhere from 20 years old to 94 years old. So that's a pretty good success rate. That's a broad, you know, if I do a study, let's say on somebody, which I did have an older population, I can't remember what my success rate was there, but I think that was 86% or 84%. You know, you get an older population, you know, they got a lot of other problems. You know, you got the arthritis. This doesn't help the arthritis. This helps if you have a pinched nerve going down the leg. So I get a patient that comes in that has severe pain down their leg and low back pain. And they come in, I say, so how do you feel? Lousy. I said, what do you mean you feel lousy? I don't feel any better. I said, well, do you have any pain down your leg anymore? No, that's gone. Well, what do you have pain? I still have pain in my back. Well, what percentage is that gone? 50%. So you did have an improvement. No, it's not enough. So, I mean, it's hard to judge. It's hard to judge the success rate. Patients need to understand what you're treating. And this is mostly for any pain going down the leg or the buttocks area. And also a lot of low back pain, because as I said, when you have a pinched nerve, and you have a pinched nerve, let's say, at levels 1, 2, 3, or 4, and this is low back pain from a pinched nerve. And as any of my patients know, I always talk about pain generators. You can have 5 pain generators causing the same pain. So my job is to try to figure out which one is causing your pain. And a lot of times it might be out of the 5, there might be 3 or 4 of them causing the same kind of pain. So you start to pick out one that's the most obvious. Maybe it's the arthritis, we treat the arthritis. Patient's 20% better, okay, your arthritis is gone. You have a pinched nerve at 1, 2, or 2, 3. We treat that. Now 60% is gone. You know, maybe you have a tear in your disc. A tear in a disc that causes the same type of pain. You treat that, now the patient's 100% or 90% pain-free. You have to have faith in your doctor. You can't say, get a shot and say, you know what, I'm only 20% better, I'm going to another doctor.
I have sciatic in my lower back, left side, and I have been coming here for years getting injections. Well, I'm starting to get tired of that. And the injections aren't lasting long enough in between shots, which would be like a couple of months. After I had an injection from you, about 2 weeks later, the pain came. My question to you is, if you look at my case and you think this would work for me, I think I'd like to jump on it.
All right, well,
I mean, I'm 67 years old, but my mind is 45.
so you're,
I don't think
so you're old. We call you a young man.
I'm gonna chase my
We
brain
call you a
out.
young man trapped in an old man's body.
But anyway, Doc,
You know, I happen to remember a thing or two about you.
yeah, I know, but I don't want to.
When I gave you your first injection, I think you lasted for years. And then I gave you another injection, it was a little shorter. And now we're just getting to the point in your pain history that they're not really working.
Correct.
So we're reaching crossroads for you. You know, we have to make a decision on which direction we're going to go. And that's a very good question. The question was, I don't know if you heard it, but the question is, you know, his injections were the little bit of interventional pain that we do, and probably 90% of the people, we do a couple injections and they're good for years. It's starting to not to work for him, and the time span's getting shorter and shorter. And that's where we start to look at maybe this procedure here. We get to the bottom of what the actual pain generator is that is not allowing you to have long-lasting relief. And we get rid of the pain generator. So you might not be a candidate for this yet. You know, like I said, I've had patients that are candidates for this. The insurance companies might not pay for it, and the patient has to pay a certain amount of money from their own pocket. When it gets to that point, I give the patients all the options, and they might choose, you know what, let me do the spinal cord stimulator trial, see if it works. If it works, maybe it'll take me, you know, a certain amount of time to save some money to be able to do this procedure. Or maybe the insurance companies, there's rumors saying that they're going to start to pay for it after January, which is just around the corner. I'm not going to hold my breath, but there's rumors saying they're going to pay for it. I don't know how much, probably not much, but or keep the spinal cord stimulator in until they pay for it, and then we can do that. Any questions? Anybody else?
Spacing between epidurals.
The spacing? Well, the spacing between epidurals, it used to be a week, maybe 20 years ago. And then the insurance company said, no, it has to be 2 weeks. So we did 2 weeks. And the insurance company said, now we got to do it 3 weeks. So now we do it 3 weeks.
It's got nothing to do with the medicine.
Well, it has nothing to do with the care of the patient. It has nothing to do with the decision of the doctor and the decision with the patient and the doctor. The decision is made by the insurance companies today. And if you don't follow their protocol, then they audit you and they take money back. But there are certain patients that you shouldn't do it more than every 3 weeks, more than a month, because you're steroids. You know, the real answer to that question is not related to insurance. The medical answer to that question would be, it depends on how it works, and it depends on the risk factors. If a person has diabetes, you tend to give less steroid. Why? Because when a person has diabetes and you give them steroid, the steroids actually generate sugar. They make you produce sugar, so your sugars go up. Then you got to chase it with insulin or the medication you take. So those type of people, I'd be very conservative in giving them more steroids or more injections. Also, patients that have high blood pressure, if they retain water, maybe the pressure will go up. patients that have flushing side effects. Some of them go cuckoo when they take steroids. You know, some women have their period for 4 months. You know, there's different reasons why you give less to certain people. So, but I'm not going to give you, if I give you one shot and you have one pain generator, I give you one shot and it doesn't work, I'm not going to give you another one. What I'm going to do is recommend something that's going to take it away more permanently, like maybe my minimally invasive spine procedure. How's that? That it? All right, thank you everybody for coming.
Thank you.
Did anybody hear something that I already told them?
Yeah.
You did? That's because you got a good memory. Everybody else forgot.